Hello and welcome to the Neurocritical Care Society podcast. This is our Hot Topics series. I'm your host, Dr. Nicholas Morris. Before we begin, please note that the views and opinions expressed in this podcast are solely those of the hosts and guests and do not necessarily reflect the official opinions or positions of the Neurocritical Care Society. Having gotten that out of the way, I'm really excited to introduce two people to you all today. I have our sort of guest of honor today is Dr. Wendy Ziai. Dr. Ziai is probably no stranger to many people in the society. She's a professor of neurology, neurosurgery, and anesthesia critical care medicine at Johns Hopkins and a senior editor for the journal Neurocritical Care. Wendy, thanks so much for joining us.
Happy to be here, Nick. Thank you for inviting me.
Great. And also joining us today, again, probably no stranger to friends of the podcast, has been a guest on the podcast himself several other times, and he will be taking over this series for me. This is Dr. Rich Choi. Rich is a neurointensivist from MedStar, Franklin Square in Baltimore, and he is the social media editor for Neurocritical Care.
Hey, everybody. How's it going?
Great. Well, Rich, thanks so much for joining us. And we haven't talked about this on the podcast before, but we've really wanted to feature more of the journal articles coming from neurocritical care. And so Rich is really going to take on that charge. And we're going to try to bring what we think is a manuscript of interest to the podcast, maybe once every 2 months. And the gracious editorial staff from the journal has agreed to come on to the podcast and sort of discuss the merits of the paper. We'll have some fun kind of picking it apart, and then we'll see, how is it applicable to our practice or the practices of those listening. So with no further ado, we're going to get started. And today, the first paper to kick this off is a paper that was recently published online, as not yet in the print edition. And the manuscript is entitled Postoperative Monitoring After Elective Intracranial Surgery in a Postanesthesia Care Unit is Safe, Efficient, and Cost-Effective. This paper was written by Arthur Wagner and colleagues. They are from University Hospital in Munich, Germany. And I'll just kind of briefly, before we get into this, this idea of where should post-op cranies where should they go, really comes down to the fact that we're all sort of struggling to make beds in our neuro ICUs. And so, Wendy, I'm wondering, one, how challenging is it for you to get patients into the neuro ICU where you work? And two, where do your standard elective post-op cranies go?
Yeah, that's always a challenging situation for, I think, all of us. We had this issue for many, many years where cases were being canceled because there were not enough beds in the neuro ICU, and all elective craniotomies were going to the neuro ICU. And so we came up with some protocols to decide which patients met certain, lower severity situations where they might be safely looked after in a neuro IMC. And so those patients, typically might go to the PACU first and then go to the neuro IMC. And those are going to be in our center patients like MVDs, microvascular decompressions, some of the Chiari decompressions that do not involve invasion of the dura, any procedure that doesn't break the dura, and then, of course, a lot of spinal procedures. So those are going to our neuro IMC, which is 6 beds, and that has really substantially offloaded the burden on the neuro ICU itself.
Great, that's interesting. So you have some criteria. They're actually quite different from the criteria that the authors used in this paper, and we'll get into that more later. But Rich, there is so much variation in this area. I'm interested in your experience now at MedStar. Where are your kind of elective post-op cranies going?
So most of them are coming to the neuro ICU, and when there are no beds available, that's when the PACU will overflow those post-op patients. And it's takes a lot of teamwork and collaboration just to figure out what patients are best suited to stay in the PACU, just in terms of intensity and, like as Wendy was saying, just in terms of severity of these cases.
Yeah. Great. That's really interesting. At University of Maryland, we by and large try to get all these patients to the neuro ICU. We almost never have a bed available for them immediately after surgery, and they end up just kind of boarding in the PACU for a while, and they end up coming to the neuro ICU sort of in the middle of the night for hopefully a short time, and then they leave in the morning after just a few hours in the neuro ICU. So the intended target is not always where they land for the majority of this sort of immediate post-op monitoring period. Great. Well, why don't we jump into the paper here? So, the authors, they mentioned some of the same challenges that we all face and that they were actually canceling a lot of these elective cases. And so decades ago, they tried to come up with a solution for this. And they here report their experience over a 10-year period from March 2013 to September 2023, using a new sort of PACU pathway for elective craniotomies that were uncomplicated. And we'll go through a little bit, the types of patients that they decided to use this pathway on. It was really any elective cranie. And so these included brain tumor patients. So they did, in fact, break the dura. They had, in fact, the highest portion of patients in this study were brain tumor patients and those with gliomas. But they included aneurysm clippings, microvascular decompressions, AVM resections, a real large variety of different types of cases here. The requirements were that the American Society of Anesthesiologists, or ASA score, was not greater than or equal to 4, so they couldn't have any severe comorbidities. They had sort of a pre-op discussion with the anesthesiologists and neurosurgeons just to sort of figure out if there were any other factors that needed to be considered. And patients who were known to require prolonged ventilation were not part of the pathway. So I imagine that was someone who was sort of prone maybe for a prolonged 24-hour surgery or something where they might want some longer time to get them extubated. And if an intraoperative adverse event was detected, they had a sort of a joint assessment at that point to decide, should we still go to the PACU or should we bypass the PACU and take this patient directly to the ICU? I think it's important when we understand these PACU pathways to figure out a little bit like, well, what is a PACU at this institution and how does it differ from my PACU? So this was a sort of very specialized PACU in my mind, because they had a pretty high nurse to patient ratio of 1 to 4. And it was small. It was only 8 beds. So 2 nurses, I guess, for 8 beds. It was a multi-specialty PACU, and it was staffed by advanced practice nurse anesthetists and anesthesiologists. Importantly, on nights and weekends, there were no anesthesiologists sort of in-house or in the unit, so there were no physicians there. And they were instructed to monitor the patients regarding level of consciousness, neurological deterioration, pain scores, etc. They could take external ventricular drains, and they did manage those. And usually part of this was some type of imaging. And then at 24 hours, the plan was to downgrade the patient to the floor if everything went well. And if there were any complications, they could consider sending them to their sort of intermediate care unit or even to their ICU. And so over this 10-year period, they had 5,553 patients that were scheduled for post-op monitoring in the PACU. And that's out of 638 total that they evaluated. So 98.5% they thought were actually okay for this plan. So the vast majority. So that means only like 1% basically went directly to the ICU. And most of the time that was for pre-existing pulmonary or systemic infections. That was another exclusion criteria, actually. If the patient had sort of a known reason to be in an isolation room, then they went to the ICU because they couldn't provide that in the PACU. The PACU patients were monitored for an average of 22.2 hours. And following this initial monitoring period, an additional 1.9% of patients were secondarily transferred to the ICU on post-op day 1. But in total, 94.4% of patients avoided all ICU admission, and they calculated this as saving over 5,300 ICU days, and that's a lot of ICU days. The complication rates they felt were acceptable, a 17.1% rate. Those were made up of new neurologic decline in 12%, rebleeding in 6%, and thromboembolism in about 4%. About 2% had an external ventricular drain inserted during the monitoring period. And most of the complications were, in fact, during that first post-op day 1. I think 80 some percent. About 16% of complications were on post-op day 2, and less than about 5% of complications were found on post-op day 3. So that was basically what they presented. And, I think it was really interesting. It's sort of a different system than currently what we use at our institution. And Wendy, I'm wondering if you could sort of, take a step back and kind of having reviewed a lot of similar papers to this, and as you're so astute with the literature, what did we know before this paper came out about post-op crani care, complication rates, and kind of where these patients can be safely monitored?
Yeah, I mean, there is a body of literature on this topic, and the authors report this 17% complication rate. I would argue that it didn't include some of the cardiorespiratory complications that we occasionally see. And I think a lot of the issue is, how do you define complications postoperatively? So there was an article some time ago from the Canadian Journal of Anesthesia, and they looked at, I think, all neurosurgical cases in the operating room, and they reported at least one complication in 55%, but nausea and vomiting was 38% of that. So, as I said, how you define complications is a big deal, because certain interventions can be done easily in a PACU or a lower monitored setting, and some interventions, especially in my hospital, intravenous analgesics like fentanyl, intravenous antihypertensive agents, can only be given in the neuro ICU. And obviously, that's going to restrict how many patients can actually be looked after in a lower level of monitoring kind of setting. So, yeah, I think they did say there are cardiac, respiratory, and neurologic complications in this older study were each quite low, around less than 5% each. So I think serious complications, I would agree, are fairly low. 17% doesn't sound like a very low number, but I think if you consider everything together, I think it's an acceptable number.
Yeah, I would generally agree with that. I was interested in the idea that some patients were getting external ventricular drains inserted in the monitoring period. It was a small number, but not all of those patients even ended up, I don't think, coming to the ICU if you do the numbers out. So they must have a different ability to handle external ventricular drains in their IMC or floor, because we currently don't manage those on our IMC or floor.
No, neither do I. And I think if we ask the PACU nurses to manage an EVD, or order CT scans for us, or even look after arterial lines, manage blood pressure, that would be a flat no in my center. So yeah, this is an amazing center that's actually managed to put this additional capacity and training, I imagine, into a PACU setting. And have to commend the authors on how they did this at this center in this very collaborative study, right, between neurosurgery and anesthesia and the neuro ICU.
Agreed. As you mentioned, this is not the first study to kind of present its own pathway for elective post-op crani patients. But I think there are the merits to the study that really make it stand out from some of the others that have been presented. In your estimation, what are some of the strengths of this study?
Yeah, so I think the data is consistent with this, 2% of patients not intended for the ICU requiring care escalation and then transitioning into the ICU. That seems to be a fairly representative population based on the other studies that are out there. And I think, as I said, the collaboration model, I think, is it's an excellent example of collaborative work between different departments to reduce the burden on the neuro ICU and to, allow these pathways to work. And they obviously do work in this particular setting.
Great. And, the authors noted their main limitation being the sort of retrospective nature of their evaluation. Any other limitations that you see when you read the paper?
Well, I think the main limitation is generalizability to other centers. And I think we've already sort of defined the PACU resources that they had available, which are clearly not representative of most traditional PACUs, at least not in this country. I would say that in order for people to feel comfortable looking after EVDs and, even doing routine neurologic exams, they would have to have a fair amount of neurologic training. And I don't think they don't sort of describe exactly what the training was in this particular center, but in a center like mine, that would require significant effort in training the personnel and in having people on the ground available in-house to manage complications, because we see complications all the time in the neuro ICU in these patients that, come for 24 hours of monitoring. And it's hard to imagine that they would be easily looked after in an alternative setting.
I completely agree. There's, I think one thing I just wanted to point about the study is just the sheer number of patients, I think is really impressive. We're over 5,500 patients. They have a lot of experience with this. And so over a 10-year period, I think that gives me a lot of security in the findings here, that we're not just dealing with a random variation from a small sample size. There have been several smaller papers of different types of pathways that I've come across in the literature. I mean, some centers are even sort of suggesting that same-day discharge after craniotomy for tumor resection is safe in some patients. There was a nice paper in the Journal of Neurosurgery from Toronto Western Hospital in 2023 where they had over 600 patients that they thought were appropriate for this pathway, and they kind of monitored them in the PACU for a while, a couple of hours, as long as they were doing well and a post-op CT scan looked okay. They actually would discharge home with a family member after just a few hours and some imaging. Really, really incredible. Those were mostly tumor resections. And then a separate paper from Maine Medical Center, also in Journal of Neurosurgery from 2017, looked at sort of maybe what for many of us might be a more realistic pathway of a few hours, I think 4 hours in the PACU, and then a transfer to a neurosurgical floor if stable. That was in 200 patients, and none of those patients ever required transfer to the ICU. So definitely there's different models here. What I'm interested in hearing from both of you is sort of how your neurosurgeons kind of generally view the post-op monitoring period. In my experience, it depends very much on whether they trained, and it can be kind of quite dogmatic about 24 hours means exactly 24 hours of ICU monitoring, or perhaps they trained in an institution like ones that we just described, where they were looked after in a PACU for a while and even went home, the next day quite early. How do studies like these, how can we use them to sort of push, move the needle towards acceptance of, I'd say, accelerated post-op pathways?
Yeah, well, that's always a challenge. What we did maybe 20 years ago, I wrote a paper that's in critical care medicine, and we looked at all the patients who stayed less than 24 hours who had brain tumor surgery and what the resource use was in those patients. And the vast majority of any ICU resources was utilized in the first 4 hours. And that was predominantly intravenous analgesics in 72% of the interventions.
Mhm.
And so after 4 hours, there are relatively few truly ICU interventions that we found would be required for a tumor patient. And just to your comment about the neurosurgeon's comfort level in early discharge, in our center, it's highly variable. There are some neurosurgeons that are very comfortable with the procedure. It depends on the procedure, of course, and would be ready to let their patient leave the ICU after a shorter period of time, especially if there are cases waiting to go, and those cases are at risk for being canceled. And then, as I said, we have this model where they downgrade, they can be downgraded to the IMC if everything is going well. And then there are others who want to have 24 hours, and that's probably based on the type of surgery, some of the risk factors. So what we found in our study was that some of the tumor risk factors that are not really described in this particular paper, but things like mass effect, midline shift, those severity factors, the infratentorial location, those were factors that really made a big difference, as did EBL, blood loss, and intravenous fluid administration, how much fluid the patients got. And then, of course, whether they were intubated at the end of the case. So those factors also played a role in needing ICU resources. So I think it's very multifactorial. And the surgeons obviously are thinking, what could possibly go wrong? And a lot of them want that 24-hour period.
Yeah, that makes a lot of sense. I found this quote from that paper from Maine Medical Center that I thought was interesting. I was hoping to get your views on it as we wrap this up. So in their protocol where they went to the PACU for 4 hours and then off to the floor, they said, we interpret escalation of care in the setting of our protocol as an extension of a care paradigm as opposed to a protocol failure because no permanent morbidity was added. All patients following our protocol were successfully managed without adverse effects on their ultimate disposition or outcome, which is great. I'm wondering, we often do view sometimes if we downgrade a patient and they get monitored for a while and end up having to come back to the ICU, that often is looked at, I think, as a failure, perhaps on the part of the intensivist or those monitoring that we sent them out, quote unquote, before they were ready. I'm wondering how things are viewed at your institutions and whether you view these as failures, and if not, again, maybe how do we sort of change this view?
Right. So we have the same issue. Patient just came off the nicardipine drip. They just got extubated a few hours ago, and we need a bed for the next post-op case or ED, wherever the case is.
Yep.
And we got to get somebody out, and that's the patient who's leaving. And everybody sort of accepts, yeah, we sent the patient out a little bit early. And if they bounce back, well, they bounce back. In my view, that's part of the game. You're always trying to, maneuver patients where they can best be cared for and most safely cared for. But we have the opposite problem as well. In every week, we will have days where we can't get anybody out of the ICU. And then it's just a big backlog, and there are no floor beds to send patients to. And that's where the real challenges are, I think.
I agree. Since we all practice in Baltimore, I feel confident I can share this. I've been on calls where we're trying to get a patient in for a thrombectomy or a recently ruptured subarachnoid hemorrhage in who needs an EVD and to be clipped. And when our beds are all full, right, I feel horrible, and I'll often say, "Well, you should check with MedStar or Hopkins." And when the answer is, "I already did," you get this feeling in your stomach of just really absolute horror and grief, right? That there's nothing you can do for this patient. And I think hopefully people realize as we're talking about pushing patients through the system quicker and quicker, that we're really, I think, motivated by the wish to take care of more patients who need our care and not less, and not spending less time with those who are in need of an ICU bed, et cetera.
Yes, well, we have the same issue. And so we have prioritized patients with aneurysmal subarachnoid hemorrhage and, of course, strokes for thrombectomy, that those patients get prioritized, and they may get an ICU bed that doesn't have a nurse. And actually, the first responders are going to take care of, Lifeline is going to take care of those patients for 4 hours until we can make a bed, so that we don't turn away those types of patients that need us the most.
Oh, wow. Do you reserve a bed for those patients? Some people have a stroke bed or a subarach bed.
We don't officially reserve any beds. However, it so happens that with nursing shortages, there is often a bed available in the neuro ICU that isn't staffed.
Got it. Got it. Yeah, I think that in some ways that was not a benefit of COVID, but it was a strange artifact of COVID that we did often in our institution have an open bed during that time. And for an acute patient, we could sort of make it happen, right? You could find a way to get through a part of a shift until you could get more staffing in. But we haven't had an open bed for quite some time. And these things are really challenging. So avoiding ICU admissions for patients who maybe don't need them is something that would be hugely valuable. All
Yeah,
right.
I think we've all sort of developed the way, I guess, local ways to deal with these issues. And it may not be a sophisticated PACU like was described in this study, but it may be something else. But I think we're all sort of trying to make pathways available so that we can take as many patients as possible and avoid canceling cases.
Great. I think that's the name of the game. Any last thoughts on this paper, Wendy?
Really interesting paper. Again, congratulations to the authors. They really have done a remarkable job. It's an amazing example of what can be done in a setting that has the resources available to do that, and a little bit of creativity, I guess, around that process. I think we'd have to really study that in a prospective way to see whether we could come up with different similar solutions in a system like ours.
Yeah, I completely agree. And I also want to echo your thoughts about the incredible collaboration that this paper showed among the anesthesiology group, the neurosurgical group, and the critical care group. That type of collaboration is admirable, and I aspire to it one day. All right. Well, thanks so much to my guests, Dr. Wendy Ziai and Dr. Rich Choi. And Rich, we're really excited for you to take over this part of the podcast and highlight the really cool papers with high impact coming out of the journal.
Looking forward to it, Nick. Thank you for having me.
All right. Well, that wraps us up for today's episode. Please like and subscribe the podcast. It can be found anywhere you find your podcast, but it's also available on the Neurocritical Care website, and select episodes are available for continuing medical education credits. Thanks again, and I hope you tune in next time. Take care.